My name is Sadia Khan, and I was the chair of the recent AHA-ACC scientific statement that accompanies the new blood pressure guidelines, use of risk assessment to guide decision-making for blood pressure management in the primary prevention of cardiovascular disease. I'm joined today by my vice chair, Dr. Lloyd-Jones, who I'll let introduce himself.
Great to be with you, Sadia. I'm Don Lloyd-Jones. I'm a cardiologist and cardiovascular epidemiologist and PI of the Framingham Heart Study. And like Sadia, I was also a member of the recent high blood pressure guidelines and, as she mentioned, also co-chair of this statement.
We wanted to get started with a brief genesis of why a companion paper was needed and give a few quick high-level points about why we even use risk. So Don, why do we even calculate risk when we're talking about hypertension?
Well, it's very important to understand why we also use risk and not just blood pressure levels when deciding who to treat in primary prevention of cardiovascular disease. We've had this paradigm of risk-based prevention in the lipid guidelines for almost 30 years now, but it's been relatively more recently that it was incorporated in the high blood pressure guidelines. So we know that when the blood pressure is 140/90 or higher, we should treat everyone with blood pressures at those levels. But the evidence would suggest that when the blood pressure is, say, 130/139 systolic, that if we take into account the person's 10-year risk as well, we're going to select those people who are going to benefit more from therapy and actually be more efficient and more effective with our decisions about who needs drug therapy immediately. And so absolute risk assessment really forms the core of decision making for these people with whom we now call having stage 1 hypertension.
So in essence, we want to personalize care. And that was really the discussion and decision around what risk tool to then use. In this accompanying statement, we go through the evidence for why the guidelines chose the PREVENT equations. As you're all familiar, the PREVENT equations were developed by the American Heart Association in 2023 using data from over 6 million individuals. So it was a very large data set that allowed us to more accurately and precisely estimate risk than prior models. We also used contemporary data, so we really had data that were relevant to the patients that we're seeing in clinic today and got us a way to calculate risk not just for atherosclerotic events like heart attack or stroke, but also heart failure. So we could really assess risk for total cardiovascular disease in a composite endpoint. Once we had the model, the follow-up question was perhaps the more complicated one, though. So, Don, how did we get to the 7.5% threshold?
Well, if you recall, Sadia, the 2017 AHA-ACC blood pressure guidelines were actually the first to adopt this absolute risk assessment paradigm to help selection specifically for people with stage 1 hypertension. They chose at that time, based on evidence from the SPRINT trial, a 10% 10-year risk threshold for atherosclerotic cardiovascular disease as calculated by the pooled cohort equations, which were the equations that were available at the time. As you just mentioned, the new PREVENT equations provide an opportunity for us to look at the decision threshold again, because with these new equations, as you mentioned, derived and validated in over 6 million Americans, we actually know that these equations are more accurate and more precise. And that means we need to look at how they match up with the data from the randomized clinical trials, where we can see at what level the likelihood we're going to prevent an event exceeds the likelihood where we might see some adverse effects from the therapy. We also want to think a little bit about what the impact of choosing a new decision threshold might have on how many people get treated. So these are some of the things that we kind of put into the hopper to make this decision. And at the end of the day, what we found, and Sadia, I think you're going to expand on this, but what we found was that a 10-year risk estimate of 7.5% or higher was equivalent to using, and that's using the total CVD PREVENT equations. That was equivalent to using a 10-year risk estimate of 10% or higher using the old pooled cohort equations, or a 10-year risk estimate of 15% or higher using the Framingham equations like was used in the SPRINT trial. So all these things actually provide equivalency in terms of who we're selecting for therapy, and that lines up exactly with the kinds of trials that we've seen, the randomized controlled data that we've seen in whom we should treat at these lower blood pressure levels. Because maybe we don't want to treat absolutely everybody right away, but we certainly want to select out those people who are going to benefit the soonest and the most, and those are people at higher predicted risk.
I think, Don, two things you said that are really important. So I just want to reiterate that is what we really were hoping to do in this paper was create a crosswalk. We weren't creating new clinical trial data. We weren't showing how Prevent was going to be used in a new trial, but actually applying it in an existing trial with the Sprint data so that we can confidently say that among Sprint participants who had a Prevent score greater than 7.5%, we see this benefit. And that I think is a really important concept. The equivalency that you said, or the crosswalk, as new models are developed, risk isn't changing, but how we calculate it is. And so this paper really helped us try to detail and explain that thought process that we had as we created this recommendation. The second thing that you said that I think is really important is how do we identify who we want to treat right away? So as we're personalizing care, we're not doing this as a one-stop shop, one and done, but thinking about for those who have a risk less than 7.5%, lifestyle intervention absolutely is going to be key. But if they still have an elevated blood pressure 3 to 6 months later, even if the risk is low, recommending initiation of medication is in the guideline as well. So we kind of gave it both perspectives. Where do you start? And then what do you do in follow up? And I think that was really important. One other thing we talked a lot about in the development of this paper was what does it mean for the US population? Anytime we have a new guideline, we talk a lot about the individual patient, about the clinician patient discussion, how the Prevent tool can be used to help personalize those encounters. But what about for the population? What did we see when we applied the risk threshold to nationally representative data?
I think it is important to take that national perspective and again, make sure that we're neither overtreating nor undertreating the people who really need it. So that's where the recommendations should really find the sweet spot. And we took, as you know, great pains to make sure that we were well aligned with current recommendations, but also aligned importantly with the randomized controlled trial data that you mentioned. So how do we do that? Well, what we do is we look at what did the 2017 guidelines recommend for therapy, and we took a whole look at the entire sort of risk-based prevention model. So what the guidelines recommend for treatment is if the blood pressure is higher than 140 systolic or higher than 90 systolic, it recommends treatment. That's a 1A recommendation for everybody, regardless of whatever other conditions or medical problems they might have. When they have stage 1 hypertension, that's systolic 130 to 139 or diastolic 80 to 89, that's where the risk estimate comes into play. But also in that range, if they already have pre-existing cardiovascular disease, if they have chronic kidney disease, or if they have diabetes, automatic treat. They are at higher risk by definition. And then if you calculate a 10-year risk over 7.5% with the Prevent total CVD model, that is a group that also has clear net benefit and we want to treat them. When we line up the 2017 recommendations with the new 2025 recommendations, what we found was essentially an equivalent number of people would be recommended for treatment under this risk-based paradigm. And that feels about right. I think, based on the randomized controlled trial data, that tells us that we are not going to overtreat nor undertreat. We're really going to target it to people who are likely to benefit the most.
And I think that's really important for patients and for clinicians. And what we really want the takeaway from this accompanying document to be that the Prevent equations are accurate and precise, that the threshold is grounded on evidence from randomized clinical trial data like Sprint, and that the implications for the population are demonstrated to show that we treat a similar number of people but more efficiently identify the right number or the right patients to treat who are at increased risk. And so we're really personalizing care. And the follow up is so important. We're talking about that first treatment decision to be made at the initial encounter with real emphasis on making sure that at the 3 to 6 month follow up, if blood pressure is still elevated, that we do consider medication at that time.
Yeah, so important because we know those patients, the blood pressure is only going to go up over time, right? It doesn't tend to go down if lifestyle is not being successful. And so they're only going to go up. And that in that case, we'd be delaying treatment for someone who is going to get stage 2 hypertension and pay the price for that cumulative exposure to elevated blood pressure.
A lot like pack years, right? Your exposure only increases as you get older.
One other thing that I think is really important that may be a misconception out there is that, if you've got someone who is now treated and you calculate their prevent CVD risk, and for whatever reason, maybe they're younger, it comes out at less than 7.5%. The guidelines do not recommend that you take them off therapy at that point. If you have already made the decision to treat their hypertension, keep them on the therapy. It would not be appropriate. This is really talking about the initiation of new drug therapy for the first time, not making decisions after the fact once that decision has been made. If you've made a decision to treat someone for their hypertension, they needed it and they should stay on the medication.
Yes, super important, and also gets to the point of target. We're talking about when do you initiate therapy, at what blood pressure level, but we also make recommendations to make sure that blood pressure target levels are less than 130 over 80 once you've initiated treatment, with a goal to get closer to 120 over 80.
Yeah, that's right. I mean, I think some of the newer trials where we're starting to compare more and more higher blood pressure goals to lower blood pressure goals beyond sprint. Now we have STEP, we have other trials as well, suggesting that indeed the closer we can get to 120 to less than 120 over 80, the better we're going to do for our patients. Now, every patient's unique. Every patient's different. We do need to be mindful that for some patients, if we lower the blood pressure too quickly or if we lower it too much, there may be some consequences. So obviously checking in, having the patient monitor their home blood pressure, having them monitor themselves for any symptoms that might be of concern. But for the vast majority of patients, if we can get them down to close to or under 120 over 80, that's really being shown over and over to be beneficial.
That's so important. As you personalize the risk assessment, we also want to make sure we're personalizing the treatment approach as well. As we think about the overall guidelines, how we use risk assessment, what's your one takeaway for clinicians today, Don?
The reason the risk-based prevention paradigm has stuck around is because it works. It is important to give patients a sense and give clinicians a sense of, how worried am I about the near term for this patient? Near term would be in the next 10 years. That's a patient where I want to be more aggressive. I want to be more intensive. This paradigm of matching the intensity of our treatment to the absolute risk of the patient actually works. And so, making it a habit to actually calculate their prevent CVD risk or their prevent ASCVD risk, if that's the endpoint of interest, or even their prevent heart failure risk, if you're thinking this is a patient who might be particularly at risk for heart failure, just making that part of our clinical workflow, I think is going to be important. It's going to help us make better decisions. It's going to help us explain those decisions to our patients better. And again, it's going to make us more efficient and more effective with our therapy so we don't undertreat or overtreat.
That's so important, right? We don't want to unnecessarily treat patients who may not benefit from it. And so this really gives us a way to make sure we're not overtreating or undertreating. For more details, please see the accompanying AHA-ACC scientific statement, as well as the 2025 AHA-ACC Multi-Society High Blood Pressure Guidelines. There's lots of great content.
Thanks so much, Sadiya. This has been really great. And again, I hope that this document will help people better understand the kind of decision making that goes into these very important recommendations for managing hypertension, which, after all, is the leading modifiable cause of death on the planet.